Right. Before we start, let's start our session today with Ummul Kitab Al-Fatihah. Okay, Alhamdulillah. We are now at 10 a.m. So I think bolehlah I brief dulu introduction. Yeah, we are very fortunate today because here we have a very I can say very fresh and energetic breast and endocrine pathologist to share something with us today, the ABC in endocrine pathology. Right. So before that, let me introduce our speaker today. She is Dr. Navarasi S. Rajagopal. She was medical graduated from Davao, Philippines in 2004. I just knowing that from your CV. I don't know that you are from Davao, Philippines. That's good. She completed her master in anatomic pathology from in 2013. Okay, and she did her subspecialty in breast and endocrine pathology in UK last year. All right, complete last year, completed last year, and now she is a consultant and head of histo unit in Putrajaya Hospital. Right? Is it true, Dr. Nava? Okay. I think it's just a very nice, very short CV given to me. And without further ado, now let's explore what is ABC in endocrine pathology by Dr. Navarasi S. Rajagopal. Okay, can I pass to you, Dr. Navar? Now the
Yeah,
floor is yours.
thank
Yeah.
you very much, Dr. Wan, for the kind introduction. Good morning, everyone. Hope everyone can hear me. Can? Boleh kan?
Boleh?
Okay. All right. So this is basically a very basic presentation. I would say it is a good revision for everyone. Okay. So let's start. Okay, just a short disclaimer. This presentation, the content is based on my personal experience and my personal approach in endocrine pathology. Mainly today we will be covering thyroid pathology. So the images here are from real patients and for academic purposes only. Okay. All right. The content of my presentation. Firstly, I will give you what you mean by A, B, and C. Actually, I have until E. Mainly covers thyroid glands, my practical approach on thyroid gland cutup or grossing, examples of cases. I expect a little bit of interactive sections, so we won't feel bored. And A, B, C, D, E, the pearls and pitfalls, and the summary. Okay. So what is A, B, and C? But in endocrine pathology, it is not always easy. A stand for atypia, nuclear atypia, architecture. Sometimes this can be a clue for you to diagnose the exact entity. And A also stand for anaplastic, not to miss out anaplastic carcinoma. At the same time, not to overcall something as anaplastic. B stand for border because in endocrine pathology, the borders of the lesion can tell you it's either benign or malignant. The background disease is also a clue. Blood vessels, because any angio invasion push it to carcinoma status, and the borderline category. So B stand for all this. C, clinical information. It is very crucial. We shouldn't diagnose anything in isolation. And capsule, as I mentioned before, capsule and border, they are almost same. And colloid, the present and absence of colloid is also a clue where to push it towards benign or malignant. And the data set, although like to describe a lot, what is important, what must be there in the report is crucial. This is important for the clinician to manage the case. And discussion means with your clinician, oncologist, or your colleagues. This is also important in difficult cases. And always not to hesitate to work extra on the specimen, extra blocks, extra immunohistochemistry, or extra sections, because sometimes when you take when you do extra workup, a lot of information will be revealed further. Okay, so that is ABC. We will touch every of these one by one in our cases. Okay, so next, it's not moving. Okay, sekejap So, okay, it's pause. Okay, so first thyroid gland grossing. I know this is very simple. Everyone knows because most of them here. Ada background noise ni. Okay. Thyroid gland grossing. I know this is very basic, but it's good to revise because some of them are junior doctors and medical officers. So basically, before you touch the thyroid gland or specimen, make sure you read the operative notes and the previous diagnosis is with you. So you must have some idea what are you working on. Okay. Then the measurements or the parameters and the appearance. Is it enlarged? Is it enlarged and nodular, multinodular, or it is firm? Because this appearance actually will give you some clue on what disease you are working on. Okay. So, and then you always have to inspect the thyroid capsule because thyroid capsule, if it is involved, it will be thickened or rough, irregular, and all this. This need to be taken. You have to take note of this. Okay, pay attention to this because sometimes when we cut, it may be retracted. So before, when the specimen is intact, you have to pay attention on that and the parathyroid tissue also. Then only we have to describe the lesion. So always remember, we follow the step, not just to fix the specimen as soon as we receive. Okay, all right. So in the thyroid gland grossing, I have my basic approach, diagnosis. You can even come up with a gross diagnosis based on the pattern recognition. So pattern recognition means, okay, is it the gland contain multiple nodules or single nodule? So single nodule basically most of the time is a solitary thyroid nodule. Or is it like invasive pattern? That means it's irregular lesion. Or the gland is diffusely enlarged. In what condition it is diffusely enlarged? Usually Hashimoto. Okay, and asymmetrical enlargement. Asymmetrical means one gland is larger than the other. So most of the time when it's asymmetry, it may point towards neoplastic process. All right, so these things will be your basic pattern recognition in thyroid gland cutout. Okay, so in the multinodular goiter, you expect to see a lot of colloid nodules, isn't it? A lot of nodules. So what is the pragmatic approach? What will be the practical way in grossing multinodular goiter? Are you going to just randomly sample the nodules or just each lobe, or how you want to approach? Basically, you have to inspect all the nodules, even though more than 10 nodules, have a look, open up each nodule, have a look. Then you have to look out for these features here. Any nodules with complete capsule, any pale or whitish or beige colored areas, any fleshy cut surface. That means they are colloid poor. That area looks different. Or any very solid looking, very dull looking area, which is different from the other colloid nodules. Any calcification or necrosis. This one you have to look for because if there is any lesion close to the calcification which looks abnormal or pale, it could be PTC. And necrosis is it's an indication for polydifferentiated carcinoma. Okay, sometimes cystic degeneration pun ada macam necrosis, but you have to pay attention. If there is necrosis, take note of that. Usually necrosis will appear like a pale yellow areas, soft areas. Okay, cystic is there cystic. Usually MNG memang there is a cystic degeneration. But if there is cystic area, look out for solid component. And other than that, if you find any firmer or solid looking nodule which look different from the other, you have to sample the area. And then every time when you sample, state the site where, right upper pole, size of that whatever lesion that you found, and distance from the closest surgical margin, then only you describe. Because if you just take and you don't describe and we want to go back to the specimen, we don't know where exactly we took from. This is just a gentle reminder for all of us. Okay. All right. So how about for solitary thyroid nodule and malignant tumors? I make it as a pie because each piece of this cake is important. So it's basically the same size, solid or cystic. Cystic doesn't mean benign. Sometimes a tumor can undergo cystic degeneration. Lesional border. Lesional border means in solitary thyroid nodule, you will have the lesion capsule. So is it encapsulated or is it irregular? Sometimes the gross itself can give you a clue there is a capsular invasion. Tumor heterogeneity. That means the tumor, is it same color or different color? Different color, take more sample. Okay, that means if it is like whitish, some area brownish, you make sure you sample both. It can represent different type of differentiation and the margin. Okay, this is from the RCPET guideline that data set. If the PTC is less than or equal to 3 cm, you have to submit entirely. Follicular neoplasm less than 3 cm, you have to submit entirely. If more than 3 cm for follicular nodule, at least 10 blocks, or block as much as you can if you worried about malignant transformation. And for tumor, any tumor, less than 20 mm, that means 2 cm or less, you have to submit entirely. This is the pragmatic approach advocated by RCPET data set. Okay, so in the checklist, these are the things you have to take note of. Focality, like example, memang they send for hemithyroidectomy for solitary thyroid nodule, but we have to still check if there is any other lesion and describe accordingly, because sometimes we can have some surprises in the same lobe, although we didn't suspect. All right. Okay. So let us start with, rather than A, B, C, let's start with FGH first. So I expect some people, please unmute yourself and give a little bit of description if you can for next few cases. All right. Okay, so this is case one. This is the gross picture. Clinically and radiologically, they thought it's benign in a middle-aged patient. Okay, so what is your microscopic diagnosis? Any volunteer? Is there anyone? You want me to pick your name or you want me to just move on? Any junior doctors, can you just describe this? Tak ada. Okay, I think I will just describe if no one wanted to describe. So basically, this is there is multiple nodules here. If you see one, another one here, and this is the largest nodule. And you see heterogeneous areas. Okay, this is one area, brownish, and then this is whitish here. This is like yellowish. Okay, let's see what it turned out to be. Okay, because it is heterogeneous. All right, but it looks encapsulated. And you have another small nodule here. Okay, so I'm not sure how many of you will guess this as malignant and how many of you will guess this as benign. Okay, because nobody want to talk. Okay, never mind. So this is the first picture. Microscopically, what you can see is this is the capsule of the lesion. You can see calcification, and here follicular pattern. And if you see only this picture, you will be thinking this is probably a follicular adenoma, or is it like adenomatoid nodule, because nothing, everything looks bland, and you can see monotonous nuclei lining the follicles. Okay, so this is one part of it. When you go, this is another part of it. Okay, so I'm sure everyone agree this is malignant. This is like solid sheets. Okay, what you can see, this paler pink, is this is necrosis, and this is what we call as peritoneomatous growth pattern, where the tumor cells are hugging around the blood vessels. Okay, so you can see these are sheets of tumor cells here, and this is on higher magnification. You can see they are quite, the tumor cells are in like nested pattern, an insular pattern, and they have almost like round uniform nuclei. But whatever it is, the architecture is not normal anymore, and you see necrosis. And but importantly, there is no PTC, the nuclear features of PTC here. Everyone agree? This is like a coarse chromatin texture. Okay. All right. So in other areas, this is what you see. I'm sure nobody will think this is like benign spindle cells, right? So what you can see is pleomorphic, hyperchromatic spindle cell, and some of it are really having vesicular nuclei, and then some have hyperchromatic nuclei. This is really abnormal. So what component is this? This is anaplastic. Okay, so this is on low power magnification. Sometimes when the stain is not so good, we may tend to miss this area. But pay attention on anything looks like this, because if you really closely look at it, this is all atypical spindle cells. Okay. Okay, so the diagnosis for this case is predominantly polydifferentiated thyroid carcinoma with anaplastic carcinoma component. There is, I just raised a possibility, if you remember the first slide, possible pre-existing well-differentiated component. Okay, that is just a possibility, but it's not going to change the management. Okay, so recapitulate the picture again. Uh, clinically nobody thought it's malignant, okay, because they thought it's MNG. But you can see three different areas. This is the colloid rich area. Okay, this glistening, a bit shiny. This is the follicular lesion that we saw in the first slide. And this is the polydifferentiated carcinoma area. As I told you earlier, the yellowish soft area actually represent the necrosis, and you can see this part, this kind of whitish area, this was the anaplastic carcinoma component. So from here itself, you can see the main part of the lesion is polydifferentiated carcinoma, and that's a small component of anaplastic carcinoma. Okay, so for a little bit on polydifferentiated carcinoma, we will follow the Turin proposal. This has been mentioned in the WHO book, where the tumor, you propose the diagnosis based on these features. Yeah, it has follicular differentiation. That means it must show the phenotype of follicular thyroid follicular cells. Sometimes you can see a little bit of follicular differentiation here and there, and also it still has the positive expression to TTF1 and thyroglobulin, and it will show solid trabecular or insular growth pattern. And importantly, there must be absence of PTC nuclear features. Yeah, and then you must have one of the following, which is convoluted nuclei, mitosis more than 3, and necrosis. I think we have seen some examples just now, right? So these are the criteria to call something as polydifferentiated carcinoma. Some authors recommended even you see less than 50%, or even you see 10% of the polydifferentiated carcinoma, we supposed to mention it in the report, because the patient, it may behave aggressively. Okay, all right. So that is part 1. Okay, we go to the case 2. Any volunteer? No one? Everyone mute themselves. Okay, if you want to describe, please angkat tangan lah, nanti host will unmute. Okay, so if you don't want, it's fine. Okay, how you will describe this is, I know this is a bit stretch, but I just want to show you something here. This is total thyroidectomy specimen, and you can see two component. Yeah, this is whitish area, and then this is a brownish area here. This looks like a papillary excrescence from far. Okay, this is another picture here. This was what you saw just now. And then when you check on the other side, there is another lesion. Okay, so focality already multifocal. But you can see two different colors of tumor. This is brownish, this is whitish. And then on further section, you'll see another encapsulated nodule. So that means what I try to show here is in one case, you can have a variety of diagnosis sometimes, not to miss them. So importantly, when we first see, we must describe properly focality and heterogeneity of the tumor. Okay, let's see the microscopic pictures. So this is a real-time case just recently received. You can see near the black arrow, this is the PTC component. You can see this is a micropapillary-like architecture, and papillary, it's a clear nuclei. Yeah? And then this side is totally different. Look, this looks solid, and you can see there's a hint of squamoid differentiation. So, what is there further about this case? I'm more interested to see this rather than this PTC, because based on FNA, they already diagnosed there is a PTC. So I'm interested in this side. Okay, again, we can see this spindle cell area. They are atypical at this magnification, not to me, they are atypical. And you can see they are epithelioid here. And you see this funny looking cells, they are not normal. So Again, this is the anaplastic component uh, in the PTC, the background of PTC. So just want to tell, anaplastic carcinoma can have spindle cell appearance, can be epithelioid looking. All right. Okay. So on our immunohistochemistry, these are the focal PAX8 expression. Sorry if the picture is not so turn out to be great, but this is the focal PAX8 expression. Uh, Here. Okay. And then some occasional cells were expressing TTF1. So what my point here is for anaplastic carcinoma, PAX8 can be a good a marker for you to prove because most of the time thyroglobulin, TTF1 will be negative. And cytokeratin markers, you have to do a panel of cytokeratin markers because they may be positive focally for certain cytokeratin only. So based on our luck, what we can get, yeah, but it will be positive. So it's good to have a panel of markers, and not to forget when you get biopsy of anaplastic, let's say anaplastic looking biopsy material, exclude other carcinoma or other diagnosis like anaplastic lymphoma before you come up with the diagnosis of anaplastic carcinoma. Okay, so all right. So to
Uh,
recapitulate, yes.
Nawa, sorry. I'm just curious. Sorry ya kacau eh.
Uh,
For the anaplastic component kat mana at the solid area yang just now that tumor yang you showed
okay.
grossly?
Okay, here, the anaplastic changes was somewhere here when I mapped back. So not all the whitish was also anaplastic, in fact. Okay, this is clearly, this was PTC, and then the anaplastic was arising somewhere here when I put back. And this was another PTC. Okay, so not
Alright.
always they are grossly distinct, but the clue is when they look different, take more sections. Okay, is that okay, Zara?
Yes.
Okay, so case 3, clinically MNG, highest score what? TIRAT 4. Okay, so yang for this specimen, it is MNG. You can see multiple colloid nodules with a thin capsule, and suddenly you find this whitish area is really disturbing. And then when you cut further, this is one whitish nodule. I think when it is like this, we have to pay attention more on this. Okay. Okay, so this is just taken from that nodule. Here, you can see this is the nodule and this is the capsule, and it is trying to, but it is not yet. Is it capsule invasion? Not yet, because it is pushing, but the upper capsule is intact. And then here it is also still appear okay. With this, we won't call it capsular invasion yet. But on further and further sections, what I found is it's already out. Okay, this is the lesion, and this was the capsule, and it is outside. So remember, sometimes it is not apparent on one section. You have to take multiple sections or deeper levels to prove that. And then always, if you are not sure, it's good to have this diagram beside us to check whether what we are dealing is correct or not. Because sometimes we also not sure. Some are really we cannot conclude is there is capsule invasion or not. But as long it is outside the capsule and it looks same, like it looks same, the population is same, it is already capsular invasion. Okay. Okay, so minimally invasive follicular carcinoma, positive for capsular invasion. I didn't find any angio invasion in this case in the background of nodular hyperplasia, because the main reason for operating this case is nodular hyperplasia, but we found this follicular lesion, follicular carcinoma in that. Okay, so it is not a surprise to find 2 or 3 diagnoses in the same sample. All right, so that is the second case, third case, and this is the next case, total thyroidectomy, goiter with retrosternal extension. Ini jelas cerita. And then FNAC, a few atypical cells. Okay, I won't tell the FNAC finding. Got a little bit more story I won't tell. So what is your differential diagnosis here? Basically this is Yes, enlarged thyroid nodule. And this is colloid poor. Definitely, they are not as shiny looking colloid, which as you see in the previous case. This is whitish. Actually, when you see um, in the real time, when you see, it is a fish flesh-like appearance. Okay, so it's whitish, fleshy, cut surface. And definitely, I'm sure everyone agree this is a malignant lesion involving the whole thyroid, and I marked here because there is a capsular irregularity here. Okay, so this was part of the lesion. You can say this is lymphoepithelial. That means probably lymphocytic thyroiditis Hashimoto here. But as you go up near the black arrow, this is already not right. Okay, there is nodular proliferation of these blue cells. These are lymphoid cells definitely. Okay, what you can find actually, most of the area I found this kind of cell. That means they are small to medium size, monotonous and low grade. And then suddenly there is one nodule. Luckily, when that was gross, I mean that was captured, looking this kind of cell which looks much atypical than this. You can see they are larger and pleomorphic. Okay, so CD20 was positive and Ki67 of that particular area was like this. I'm sure marginal won't be giving this much of Ki67. So it is actually extranodal marginal zone lymphoma with high grade transformation. This will be the best answer that we could give. Just to highlight here, for in thyroid glands, this is underdiagnosed, not diagnosed properly during the earlier workup. This is the first presentation. So definitely look like this is, and from the lymphoepithelial background, look like arising from the thyroid itself. Most commonly, we will have extranodal marginal zone lymphoma or diffuse large B cell. The other lymphomas are rare. Okay, next case. Okay, next case. This is also enlarged, large, highest score is TRAT4. Please describe. Anybody want to describe? If no, I will just describe because time is moving fast. So basically, this is also colloid poor, but they are not as fish flesh as previous. They are whitish kind of, but then tan in color, and there is some area of a hemorrhage. Okay, like brownish. This is a hemorrhage. Okay. Uh, right. So this is the finding. What my first thought when I saw this, because the base FNAC was suggestive of polydifferentiated carcinoma. Okay, what I can see actually, first time when I saw, I was like I was a bit confused with this case. It is look like polydifferentiated carcinoma, I agree, but something really was like I was unhappy because the cells are going in between the follicles. They are, you can see the follicles are intact here. The follicles are intact, and then suddenly this neoplastic population is going in between. They are splitting the follicles in between, yeah, and then they are trying to form some pattern. Are they really follicles? Are they really follicles? This kind of, it's like kind of tubular structures like this. So let's see the next picture. Again, I saw something like this. Are they trying to attempt to form follicle? I'm not sure. But the morphology, the nuclear features are quite high grade. And you can see these structures here, so-called the rounded structures has these red blood cells, some of it, yeah. And again, you can see what are these? These are vascular channels, actually, and they are lined by atypical endothelial cells, and some of it got red blood cells. You can see these thyroid follicles in between. So immunohistochemical studies, it is CD31 positive. In fact, I said it twice because CD31 sometimes you cannot really, they can be positive from like macrophage, things like this. And then ERG was also positive. Okay, so the diagnosis angiosarcoma. I did a panel of cytokeratin, TTF1, thyroglobulin, calcitonin, SMAX 100, and few more markers, just to make sure it is not um, the outcome of a differentiation from anaplastic carcinoma, but I cannot prove any PAX8 positivity. So based on the macroscopic and microscopic finding, I favor angiosarcoma likely from thyroid origin, but however, I put a clinical imaging correlation is needed because this is very rare in thyroid, because there are some theories. Yes, angiosarcoma can be from thyroid. However, because it's due to its rarity, we have to make sure that it is not a differentiation from anaplastic carcinoma high, means the one end of differentiation towards mesenchymal differentiation ke apa ke, but I cannot prove because there is no well differentiated component, or tumor well differentiated means PTC or follicular carcinoma component, or there is no markers that can prove it is anaplastic. PET was negative, everything else was also negative. So I conclude as primary angiosarcoma of the thyroid. So there is some paper here. Actually, apparently, most of it are case report because it is rare. Okay. Okay. Case 6 and 7 got some same features. So I put it together. This is also our patient who presented with solitary thyroid nodule. But I don't have the picture because this was way back like 5 years ago. And the lesion was having variegated appearance. It was solitary thyroid nodule, no doubt. But the look of the solitary nodule was variegated. That means some of it yellow, brown, whitish mix like that. Okay, so this was the finding. This was the finding here. What you can see these cells, they looks clearer than this. Okay, they looks different from this. Agree? Okay, and then here better picture. Of course, I shouldn't put this first. You can see they are different from the thyroid. Usually what you see as microfollicles or thyroid origin. They doesn't look like thyroid follicular cells, but they have some clear cytoplasm. You can have clear cytoplasm in follicular lesions, but just it makes me think of something. Okay, let me go back. Okay. And then I did this stain X. I won't tell you now. It was positive. Okay. So let's go to the next case. This is operated for nodular hyperplasia. This patient got no other illness. Okay. When we sample the largest colloid nodule, and then incidentally, I found again this population 3 mm focus in the one of the adenomatoid nodule, okay, in this population. And then it was negative for thyroglobulin, exactly this group. And then what happened was I attempted many other markers and everything was vanished during the subsequent immunohistochemistry. So the report, I put the nodular hyperplasia, but with a comment, a clear cell change noted focally, which was negative for thyroglobulin, but they expressed vimentin. Unfortunately, they vanished on subsequent section, and then commented it is prudent to exclude the minor possibility of clear cell tumor mets, especially from renal origin. And the radiologists carry out further imaging workup based on these features, and we found metastatic renal cell carcinoma. The stain X just now was RCC stain. So both of these cases were reported with our neurosurgeons from Serdang. This is the asymptomatic thyroid nodule as an initial presentation of clear cell RCC. Okay, so this is those clear cells. Yeah, and then this subsequent case, this is case A. This is also our patient. History of PTC 4 years ago, no doubt, just PTC, they did total thyroidectomy, and then suddenly patient have tumor bed recurrence. How would you describe this? Okay, this is they label as tumor. Okay, that's all. Label as tumor, but somewhere close to thyroid bed lah, neck. Okay, so this is like rubbery, when consistency, and then it has this whitish lesion here, and you can see I don't think it's well circumscribed. It's actually infiltrative edges. Okay, so this is on low power. It is just on low power. What you have to know is this is spindle cell lesion. Okay, spindle cell lesion but looks bland at this power. And then on higher magnification pun low power lah, but there is an infiltrative borders and mitosis 2/10, that's very low mitotic rate, no necrosis. Basically, everything was bland like this one. Everything was bland. Nothing more than this. So, multiple immunohistochemical studies were done, and the beta-catenin positive was proved, nuclear positivity, and some SMA positivity was noted. But cytokeratin markers, SPECS8, everything, TTF1, all negative. Morphologically, itself fit the diagnosis of fibromatosis. Okay, so the diagnosis we offered was recurrent fibromatosis. This is a locally aggressive tumor due to its infiltrative behavior and has propensity for recurrence. And this patient has a few recurrences. There's no evidence of recurrent papillary thyroid carcinoma. Importantly, we have to mention that although it looks fibromatosis, you still have to look for recurrent PTC because sometimes the PTC can have this fibromatosis like stroma. And then the morphological and the immunohistochemical features are not in favor of anaplastic carcinoma. So sometimes the spindle cell lesions can be also tricky. Okay. So this kind of desmoid tumor or fibromatosis, people postulate this can be due to the trauma, local trauma after the thyroidectomy. Okay. Case 9, since nobody want to describe, let me describe. Okay, this is FNAC. A sonographic report, a suspicious thyroid nodule in an elderly man with extra thyroid extension. This one, our radiologist did the FNA. Okay, all right. So what we see here, okay, at least atypical cell, single atypical cells, but this is MGT. Do not always overcall MGT. Stain sometimes looks very, it looks kembang dah. Okay, but there are atypical cells. And then again, this picture, because the cellularity was very low, I cannot take more because this is what I got. And then you can see this atypical single cells, and this look kind of a gland or follicles. And then again, if you see this, you may call this PTC. Look like some kind of branching architecture. And you can see some cells are nuclei are elongated, but I don't see much groove. But there is like a vesicular nuclei. So I wanted to call, could it be PTC? Because the clinical radiological features look like a thyroid neoplasm because it has inside the thyroid, the epicenter was inside the thyroid and it's going out. This is what they describe. But I was not happy with the single cells here. PTC don't usually give you this single cells in the background, atypical cells. And this is another cluster. Okay, let's zoom. We saw this nuclei, and I wasn't happy to call it PTC because yes, it is clear, kind of clear, but not many. Oh, is this groove? But okay, and in one glance, I don't see any groove, but there is nuclear crowding, definitely. Definitely, they are atypical. Okay. Okay, this was the cell block. Luckily, cell block got some material. You can see this group. Okay, this group, you can see columnar cells, pencillate nuclei. Okay, and here this is the atypical cluster again. This is a kind of elongated nuclei in a columnar cells, like a strip of epithelium, but they are not. They don't have any PTC nuclear features. Definitely something atypical, something most likely malignant. So what is this? Okay, so we go for further clinical information. Patient at advanced stage of colon carcinoma, T4, ascending colon tumor. So I did some immunohistochemistry. Luckily this time, so the CK20 was positive and the others were negative. So we conclude as metastatic carcinoma, likely from colon primary, and no operation was carried out on this patient because it is managed at stage 4 colon carcinoma. Okay, case 10, this was a referral case from one of our neighboring hospitals. And then this was the 70 tumor, solitary nodule, thyroid capsule intact, margin clear. Okay, this was the nodule. You can see this is the lesion. This is outside. It is compressed. there is a capsule, so most likely it's a solitary thyroid nodule, but macro follicular pattern. Yeah, definitely it is neoplastic, but how far we can go? Here, this is the like a shoulder of the area. This is the capsule, and suddenly this trying to come out. This trying to come out. This is like a capsular invasion. It is like capsular invasion. Okay, and then more surprises. There is a zonal change. That means this the macro follicles that you saw is this, and then suddenly some part of the lesion got this kind of nuclei, pale area. Also two type of nuclear groups. Now the macro follicles with this hyperchromatic nuclei, they don't have any PTC like nuclear features. And here this pale area got nuclear clearing, and then irregular nuclear membrane. So is this PTC? And then what is this? What all these are within the same nodule. So I'm sure everyone is interested in this group, the gray zones of the thyroid neoplasm, where everyone has problem with this diagnosis of follicular pattern thyroid tumors, where when you call NIFT-P, when you call this well-differentiated tumor and things like this. So basically, first of all, this kind of tumor category where you have we cannot tell either it's follicular neoplasm or papillary carcinoma, when you can't really make out because you have both features and all this. There are few criteria that we have to delineate first. First, a few criteria, take note of this. First of all, it must be follicular pattern. Almost 100% must be follicles. No, first, if you want to call this group, first the most comfortable way of categorizing everything must be kalau boleh, most of it or almost all follicular pattern. And then uh, no high grade nuclear features. No high grade features. High grade features means mitosis, necrosis, these are high grade features. Okay, that's why we call follicular pattern thyroid tumor. So must have follicular pattern mostly. Capsular invasion can be questionable. Until last one can be questionable. This is vascular invasion, can be present, can be questionable. And the nuclear features. The nuclear features can be look like a papillary thyroid carcinoma, can be not, can be very vague, cannot really distinguish. So how you want to categorize them? So basically you categorize them. If clear cut, no capsular vascular invasion and no nuclear features of PTC, it goes follicular adenoma, no problem. But then let's say it has no nuclear features of PTC and there is capsular and vascular invasion, no problem, follicular carcinoma. When the nuclear features are absent, but you have questionable capsular or vascular invasion, it's follicular tumor of unknown malignant potential. But when you have nuclear features, some nuclear features of PTC, but you cannot sure it is not really 100% PTC with nuclear features, then if you can't really push it to papillary carcinoma, we will conclude as for well-differentiated tumor of unknown malignant potential when do you have any of these questionable. Okay, so when you have capsular or vascular invasion and then the nuclear features are ambiguous, it is the well-differentiated carcinoma. Okay, so you can refer to this table in WHO book where you have a nice, jadwal like nuclear features, PTC present or not, then you go for capsular invasion. Ada ke tak ada? So you choose one of it. But before we choose one of these, the grossing must be proper. That means we really have to sample it thoroughly so that we don't undercall things. Sometimes we do overcall, but make sure we don't undercall because undersampling. Okay. So this is another referral case. Another thing about the previous one, the NIFT-P or these groups of unknown malignant potential, I think it's best to discuss with another experts or more experienced people before we render this kind of diagnosis, because these are not common. So we shouldn't release this kind of reports quite often. This should be after thorough investigation. Okay. Okay, so next case 11, referral case, primary diagnosis of anaplastic thyroid carcinoma. this was actually labeled as inferior thyroid nodule. But what you can see is it at this point, you can see this is a well encapsulated lesion. Okay. And then you have this kind of pattern. This is, yes, spindle cells, I agree. But at this magnification, I don't see much atypia. And then again, you can see here, they looks quite bland. But the mitosis was about 10 mitosis. Yes, mitosis, but no abnormal mitosis. And then no definite nuclear atypia. Okay, the P63 was diffusely positive, and then the CD5 highlight the lymphocytes. Okay, so this spindle cell lesion, the lymphocyte were also positive for TDT. I written back the slides with other TDT lah. I didn't take picture. And the spindle cells were negative for all the thyroid markers and then neuroendocrine markers, everything CD34, 100. But they are positive for cytokeratin, and P63 was diffusely positive. But the whole nodule, I don't see any thyroid tissue. And I don't see any glandular differentiation. What you see is this spindle-looking cells and then intervene by lymphocytes. This I be diagnosed in favor of ectopic features are in favor of ectopic thymoma. Okay, so the spindle cells have to be careful. Not all spindle cells are anaplastic. Okay. Okay, case 12, anterior neck swelling, query thyroid malignancy. So this was a core biopsy done in our one of the neighboring hospital, and this is atypical spindle cell. They have eosinophilic cytoplasm, and this is on higher magnification. You can see, this is a abnormal. It's definitely malignant, and they have quite a moderate amount of eosinophilic cytoplasm. Yeah. Okay. So are they anaplastic or not? That is the question. Okay. SMA was positive. Desmin was positive. But PEX8, TTF1, cytokeratin markers, everything was negative. So the biopsy sample shows malignant spindle cell neoplasm with evidence of smooth muscle differentiation. On balance, at that point, we favored the diagnosis of leiomyosarcoma of anaplastic thyroid carcinoma. And we didn't find any thyroid tissue in the biopsy. So we just want them to exclude if it is actually from neck going into the thyroid or anything else metastatic. So that one is the clinical correlation is needed for them. But importantly, we don't overcall this anaplastic thyroid carcinoma at this point of time. Okay. All right. So let's recapitulate of what I have discussed to you in 12 cases just now. Grossing and sampling mixed tumor component are always possible, and not to miss high-grade transformation. That is important. Spindle cell lesion in the thyroid area, you can have anaplastic carcinoma, yes. Besides that, you can see the rest, angiosarcoma, fibromatosis, leiomyosarcoma, the last case, and then thymic origin, thymoma. Lymphoproliferative disease, we saw B-cell lymphoma, can also occur in thyroid. Encapsulated tumor, the capsular invasion, the importance of identifying capsular invasion. We saw just now capsular invasion, right? And then follicular pattern neoplasm, the NIFP and all that. And then metastatic disease also can happen in the thyroid. So basically, last 10 minutes, what is the ABC? Now, FTA semua sudah habis. No fun also in the game because nobody want to participate. So ABC, the pearls and pitfall. A for atypia, B for border, C for capsule. Let's see what is that. Atypia, the nuclear atypia, you have to pay attention. Sometimes the cis lining cells can be reactive and look atypical. So not to overcall, but still atypical. We have to call it atypical, but just take precautions. Sometimes it can be benign. And then this kind of atypia compared to this is favoring towards PTC. You can see here, there is a crowding, there is a nuclear groove, and there is a powdery chromatin pattern. So this and this, they looks almost same, but just that this has more features. So when you interpret atypia, just take caution. And architectural atypia, it is benign or malignant, this papillary. Okay, you have a look. This is all papillary structures. My question is, are they benign papillary structures or malignant, neoplastic? All right, so take note of the nuclear features. Again, same patient, yeah. Take note of the nuclear features. They are all basally located or they look scatter, same only. They are small and dense. Okay, here high magnification, it's round. Yes, some crowding, don't overcall. Crowding, yes, but little crowding and the nuclear membrane is smooth, they are round. Compared to this one, the nuclear features are already start to be different. Take note of this area compared to this. So on this is the higher magnification of the earlier case. You can see this paler nuclei. This is PTC. You can see nuclear crowding, enlarged nuclei with some overlapping and nuclear membrane thickening, irregular nuclear membrane outline. Okay, so actually here I don't find much group, but this was PTC. This is PTC. So CK19 can be used. So this was the benign papillary structures that I showed to you, which was negative for CK19. And sometime in the benign papillary hyperplasia, you can see focal CK19 expression. But in PTC, usually you have diffuse CK19 expression. But remember, all these markers should be used in adjunct only. Okay, so that case, the benign papillary structures that I show you, this was the picture. This is a colloid rich nodule. And then the papillary hyperplasia was here. So it is important what we are, go back to this. It's good to always correlate with the gross specimen. Most, it's all MNG. But take note of this yellow arrow, this nodule. Okay, this is color rich and this is appear dull compared to this. Take note of this small nodule. Okay, all right. So the small, the yellow nodule. This was this is the lesion of the dull nodule just now. The border is circumscribed, at least it is benign, but it has different architecture. So now the architecture atypia, they at this power you don't see any follicular pattern. It looks different from the adjacent follicles. So this was the actual pattern you can see. This is actually a parathyroid hyperplasia. Clinical information, actually this patient also, they also remove all other four parathyroid glands. They are hyperplastic. So, and then the thyroglobin was negative. I just did for fun so that I can show to you. Usually I don't do if it is clear cut. It's good to do. Okay, so this is intrathyroid parathyroid hyperplasia because the rest of the glands are hyperplastic. Okay, so B and C borders. A, just now atypia architecture, different architecture you have learned. Okay, so capsular invasion in the follicular neoplasm, the border and capsule plays a big role because it will tell you benign or malignant. This is a capsular invasion in a very young patient presented with follicular neoplasm. Okay, this one. So it is important because it will tell you whether it's benign or malignant. So border and capsule. So you have to take more at the tumor lesional interface. You have to cover more samples at the tumor border, yeah, the capsule and the adjacent tissue. So last few slides, A, B, C, D for this case, okay. A, architecture. This is microfollicle. Can you see? All these are microfollicles. There is architectural atypia. First, architecture. Okay. Number two, borders. Is it encapsulated? It is encapsulated. Okay. Yes, it is encapsulated. But just check here. This is something funny. And then this one a bit coming out, but not enough. Sorry. But if only this, tak ada apa-apa lah. But I'm worried about this. This looks exactly like this, and this is outside the capsule. Sorry, it is capsular invasion or not. So the diagnosis, it is a follicular neoplasm. If it is no capsular invasion, follicular adenoma. If there is capsular invasion, it will be follicular carcinoma, minimally invasive. So D, deeper. D for deeper section. And E for extra sampling. So when you take more of this lesion or you do deeper sections, there was this, thing already go up. So this is the capsular invasion. So always refer to this if it is outside, not always much too. but not complete mushroom belum boleh. So sometimes you do deeper sections and see. Okay, that is capsule invasion. So that is the importance of borders and capsule and deeper sections or extra sections. So A, B, C, D, E already. And then this is another case to show you about the capsule and colloid rich or colloid poor. Okay. First of all, these are all, what is this? Maybe microfollicles, I'm not sure. But it is not, something is not right lah. Kecil, small. Something is not right. Does it looks lesional. And then this kind of pattern is really disturbing. And this is on higher magnification of this. So it's coming out and it doesn't look like microfollicles. Actually, it look like a solid small clusters, but can be microfollicles, not sure. So actually this was from a parathyroid gland, one of the parathyroid gland for renal hypercalcemia. This was what you saw here. Okay, so it looks very bland, no mitosis, except for that. But I did extra workup levels, and then it turned out to be like this. It's not really capsular invasion. So actually just like, because of the lobulated appearance, but it is still respecting its boundary, and the Ki67 is less than 1. It is still concluded as parathyroid hyperplasia. There is no other abnormal features to suggest malignant potential. As I mentioned, the lobulated nature at different plane may mimic like a capsular invasion, but it is the invasion not going outside the capsule, and it itself doesn't define the parathyroid malignancy. This is to tell parathyroid carcinoma is actually rare, so need to be interpreted with caution. We shouldn't overcall. I know we also had previously may make some mistakes because we don't have much cases. It's rare, so have to be careful. So D, again, D for data set. This is the minimum things you must have in your data set in your reporting. There is more than one component of malignancy, you have to mention. Kalau ada anaplastic, please highlight. Single or multifocal, maximal tumor dimension, vascular invasion, any extension beyond the thyroid capsule, surgical margin, lymph node status, presence of parathyroid gland, and background abnormalities. These are all must be in your report. So not to hesitate, please not to hesitate to do additional workup if you receive a thyroid specimen, when especially you are not sure. Don't hesitate to go back and recheck, at least a final check before you release the report. For the junior doctors, for a reminder for myself, we shouldn't mutilate the specimen. Keep the orientation, take the photograph so that it's easy for us to recapitulate what we saw in the slides. Additional sampling, additional sections, and additional markers when necessary. Okay. So extra workup, this is the example of extra workup which give me a good outcome. This is the main lesion, neck fullness. Patient did ultrasound, got one suspicious nodule, apparently one suspicious nodule. FNAC, we can only call it follicular lesion or of undetermined significance because of the microfollicles. Yeah, too many microfollicles, but I didn't find any lymphocytes infiltrating the follicles. Grossly, it was mildly enlarged thyroid gland, diffuse enlargement, and then I cannot find the suspicious nodule because the suspicious nodule, they said 2 or 3 cm. I cannot find. Everything was like this. Everything was a vague nodularity, and this is like a lymphoepithelial. As I told you, there is a lymphoid follicles, and these are all thyroid parenchyma. So the diagnosis, the main diagnosis here was Hashimoto thyroiditis. However, because the radiologist said suspicious nodule, although during the initial check I didn't find any, hati tak sedap. I went back to the specimen. Okay, all looks safe. But then suddenly when I recheck, I found this vague 4 mm pale area, paler. Everything was pale, but I found this paler looking vague nodular area in the one of the in mid portion of one of the gland. Yeah, and then I found this. Luckily, I just sample in case take one block, and then what I found was papillary thyroid carcinoma. So the moral of the story, if you feel like recheck, go and recheck. You may find something new, and then that's radiological finding sometimes is a guidance, but not always we have to rely on that. We have to do our thorough checkup. And other thing is that because when we take extra block, we can tell even it is a microcarcinoma whatsoever, PTC was there. Okay. And the other lesson is in the Hashimoto thyroiditis, as you saw earlier, the case, remember the lymphoma? It can turn out to be either lymphoma or you can have PTC. These are the common complication of this entity, Hashimoto, or occasionally oncocytic lesions. Okay, so why we have to be careful in diagnosing different kind of lesion with caution? Because, okay, you remember in the thyroid lesions, we can actually have different patterns, yeah, and then different category. Benign, low risk, example, NIFT-P, well differentiated tumor of unknown malignant potential, capsular invasion only, they are all low risk. Well differentiated follicular carcinoma, PTC. Polydifferentiated anaplastic can be secondary or can be other special type like lymphoma or sarcoma, because each of these entity has a different management approach, different risk category, different prognosis. So it is our responsibility to give a correct diagnosis to our clinician and for patients. Okay, so in summary, every step from the clinical information until you make a diagnosis is crucial, not to miss any of these steps. Okay, so with that, I thank you. It's already almost 11 o'clock. And my main reference is always WHO book, and for the data set, you can refer to the RCPET data set. Okay, with that, I conclude. I hope everyone can understand something from my presentation. Yeah, thank you very much.
All right, thank you. Thank you to Dr. Nava for a very comprehensive and fantastic sharing from our fresh breast and endocrine pathologists. All right, I think everyone will agree with me that this is really interesting sharing. And any question, do you have anyone who have question? You can just unmute yourself and ask a question here. I don't see any question in the chat box for me to read here. So for any question, uh, we invite everyone just to directly ask here. If I was given the chance about the ABC, I think this is very interesting, Dr. Nava. Where do you get the mnemonic for this, the A, B, C, D, E, and everything? Are you do you create by yourself or from anyone else?
Oh, actually, I'm not sure if it exists or not. It suddenly came to my mind because Suguna was asking me to give the topic. So I thinking of this. What shall I do with endocrine, because it is a very complex subject. So I suddenly thought of this. Why shall I suddenly thought? Oh, architecture. Oh, border. So I thought it's okay. Just call it ABC and approach in that way.
All right.
So
So meaning that the mnemonic is from you,
yeah.
totally from you, not from any books or other speakers before, right? So
So,
that's good. I think very nice. We can use it and you can apply for copyright for that mnemonic. I think that's interesting. And for me, for the A, I think if you ask me, I think I like to call the A for architectural first, and the second A for ATPR maybe. But of in thyroid pathology, architectural is very very important. I think under especially under low power. More than 50% of the diagnosis you can make based on the architectural pattern of the thyroid architecture first. Please don't go to the high power for the thyroid. Please try your best in low power, see the architecture, and if you're suspicious, only you see under high power for the nuclear ATPR. Right. Any question I can see from the chat box? There's not a question. Okay,
Uh,
Dr. Moha.
Mohon.
Alright, okay.
Sorry, saya in the middle of somewhere sekarang. Tengah sesat dekat mana entah ni. Actually, tu ada siapa nama dia? Suruh saya jadi moderator, but I'm not sorry. Yes, I would agree with one lah, because A is good for you to put as architecture, not ATPR. Because I still remember one of my my what we call it, my supervisor, Prof. Robert Tolina, he said, please, please, please look around under low power first. Don't make diagnosis based on high power. I mean, don't see ATPR first. So make sure you see what we call it, architecture. How does the cell arrange themselves first? Whether it is papillae, whether it is what we call it, whether it has multiple nodules, and also if you still stuck with the architecture, please ask your colleague. Means colleague is radiology. So if radiology thinks it's multiple nodule, then it is what it is. What it is. So I think it's good for Nava had this what we call it, mnemonic, but I think just change it from first is architecture first. I agree with one lah. But very good, Nava. It's very good. What we call it, how you approach that.
Oh,
But I
okay.
think yeah.
Dr. Moha, actually, I put ATPR kan, because
Yes.
in my mind, ATPR
Uh,
can be nuclear or architectural ATPR. So itulah. So because we usually
yes.
jump ATPR as nuclei, but it is not.
Yeah.
ATPR
Yeah.
can be nuclear
Yes.
and
Uh,
architecture.
Yeah.
yes. Architecture.
Yeah, so the conclusion is architecture. You see the
Yes. Architecture
architecture and see the
first.
when you see the architectural atypia, so then zoom to see the nuclear any nuclear
Yes.
atypia.
Yeah.
Yeah.
Actually, based on my experience, also most of the cases, I think most of the case that was referred to me is you want to differentiate nodule. It's not. I think between NITFI, follicular adenoma, follicular carcinoma, or what we call it. Yes, between these things, I think these three lesions is difficult for all those junior pathologists for like secondary lesions, for example, anaplastic, polydifferentiated. You can easily make diagnosis that, because sometimes for anaplastic, usually clinical can give us diagnosis, isn't it? So the three, what call it, NITFI, follicular variant PTC, and follicular adenoma or follicular carcinoma. That these three is quite difficult, and you still have to remember that follicular variant PTC is still the most common, I think. So you should think of that. You exclude PTC first, and then baru you fikir benda lain. Itu based on my experience lah. Seeing what
All right. Okay. Thank you, Dr. Moha, for the sincere comment that, especially actually, Dr. Moha and me, I just come back from my sabbatical in HQ Hospital Queen Elizabeth, and we have a long discussion on one topic, which is the topic is fall under gray zone in thyroid pathology, which is the encapsulated follicular pattern of thyroid tumor. Yeah, that's very, very tricky, and a lot of referral for that problem, for that case. Actually, I went there to see more breast cases, but end up with thyroid cases more and more, because yeah, here the ratio for me myself, the ratio about referral thyroid to breast about 4 to 5 to 1. 5 thyroid cases, 1 breast cases, meaning that we have more dilemma in thyroid cases. So thyroid, although it is ABC, looks very simple ABC, but in real life, thyroid is complicated and challenging, more challenging compared than breast, isn't it? All right. Anyone else want to say something to us or to comment? We have another few minutes. I allow another few minutes for this. Yeah, it seems no question. Everyone just say thank you for your excellent presentation, Dr. Nawa. Very interesting and informative lecture. Okay. So if there is no more, we can, I think, Yeah, we can end the session here. For Muslim, we can end the session with Tasbih Kafarah and Surah Al-As.
Oh, Dr.
And
Wan,
now,
Dr. Wan, Dr.
yes,
Wan, wait.
yeah.
I just would like to make announcement for the next month topic. Before that,
All right, okay, okay. Now, any housekeeping announcement? Yeah.
right. Hi everybody. Uh, just a short announcement. Okay. So next month we'll be having I'm not sure what you're seeing. My presenter slides. Okay. Anyway, next month we'll be having a lung topic by Dr. Nur Salma, which is approach to limited diagnostic material for lung cancer according to 2021 WHO classification. So please keep keep this date and make it free on the 30th April. Same time 10 to 11. And before that, I hope you can give feedback. I think I've posted as well in our WhatsApp group. We appreciate it very much. Thank you.
Okay, thank you everyone.
Oh, thank you, Nava. A
Thank
very
you.
excellent
Thank you, Zara.
presentation. Oh,
Thank
I just have one question.
you.
um,
Allah.
my question is very simple je. Tak ada kena-mengena. No worries, no worries.
Uh.
How frequent do you take pictures? Just
I don't usually take, and then the moment you decide me to take, do the presentation, all the cases comes in. So, and except for the RCC case that we published, usually I don't take, because it, not don't want, but we are very busy.
okay.
Yeah,
I
but
found I found that pictures are quite helpful. I mean,
yeah,
from my my training with Doctor Rosna, especially you might not be the first one to see the specimen, or maybe you become the
yeah.
second or third referral. Then pictures really helps. So. And of course, afterwards, CPC or like your said lah, presentation and everything comes up. Mm.
Betul. And then it's also for us to easy to discuss with our colleague kalau dah ada gambar. So macam junior doctors pun I usually ask them, can you please show me first? It's easier. Actually, it will save a lot of time if we actually inspect the gross specimen, especially for difficult cases.
Yes.
Okay, thank you.
Alright. Thank you, Nava.
Nava,
Ah,
Nava, hold on.
ya kak.
I got message. Someone asking question in chat box, but I couldn't find.
Ah,
Okay, sorry. May I help then, Dr.
Yeah.
Wan?
Yes,
Alright.
yes.
Okay, it's a question from Dr. Hemlata from HKL. What is your opinion on the term adenomatoid nodules microscopically?
my opinion, adenomatoid nodule means it is still benign nodule. It is arising in the background of nodular hyperplasia. It is usually it's a dominant nodule or a nodule which mimic like a follicular neoplasm, but it is not. But remember, there are cases where we cannot really call it adenomatoid nodule or follicular adenoma, but the outcome is same because it is benign. Either you call it follicular adenoma or adenomatoid nodule is not going to affect the management as long as you don't miss any capsular invasion or not. Because, but remember to call it something as follicular adenoma in the background of nodular hyperplasia, you must make sure most of the time it is mainly microfollicular architecture and it has a thick capsule. But you, on the other way around, you can have completely encapsulated nodule in the benign conditions as well. But usually they have a mixture of follicular size, macam normo, macro, and micro follicles. So you have to interpret with caution. You can find adenomatoid nodule in the microscopically also. But remember, the impact is not much. Whether you want to call it adenomatoid hyperplasia or follicular adenoma. So you can find, But and what else, Dr. Hema? Can you unmute? Anything else you want to know? This is how much I can tell in the impact of the management. Yeah.
The
So
question is still general. I mean,
yeah.
what do you think? Not what actually Dr. Hema wants to know about the admitted nodule, because the question very general.
Okay. Example, maybe Dr. Hema, you might be thinking in the solitary thyroid nodule cases. Is that what you
No,
mean?
I think she wants to know about the microscopically, because she asked
Uh,
microscopically just now.
oh.
Yeah, I mean the term. What is your opinion on the term adenomatous nodules microscopically? So
Okay.
here is about the term, and then a second is about the microscopic features. I think that's 2 point in this question.
So it is a benign nodule, but it is not adenoma. It is one of the hyperplastic nodule. When you call it adenomatoid, it is not adenoma. Adenomatoid means adenoma-like. Okay. So if Dr. Hema, you have further clarification, you can call me or you can unmute or we can discuss later.
I think
Yeah.
macam ni
Okay.
Nava, I rasa saya pun macam discuss dengan Wan hari tu lah. Memang my junior pun tanya whether adenomatoid nodule tu kita nak put dalam interpretation or not. For me, saya tak letak dalam interpretation adenomatoid nodule. I just put that my interpretation, for example, right thyroid nodular hyperplasia. But in my microscopy, I mentioned that there's a dominant nodule with these features. However, I don't see capsule. However, I don't see nuclear features of the carcinoma because what if you put in the your interpretation adenomatoid nodule in the background of apa dah nodular hyperplasia, sometimes the surgeon will call you back because what do you mean by this? So for me, I just explain in the microscopic biodiagnosis should be as short as possible. This is nodular hyperplasia. It's just like that for me. Because yes, like Nava said like just now, tubular normal, follicular adenoma or adenopathic nodule, it is two different entity. Adenoma is neoplastic, which is benign neoplastic, which is dominant nodule actually is hyperplasia, so it's not neoplastic. So it is totally different. Because if you say neoplastic, tubular nodular apa follicular adenoma, it can be follicular carcinoma, but if nodular hyperplasia or dominant nodule in nodular hyperplasia, it's not neoplastic process. So you should, for me, you just put in your diagnosis is thyroid nodule, nodular hyperplasia like that. But your description, yes, you mentioned there is a dominant nodule there, which this dominant nodule can be seen radiologically or sometimes clinically. Okay, just
Yeah.
that you just mentioned that. I think because clinicians confused with this usually because we have so many juniors, not only juniors pathologists, but also you have to remember junior surgeon. So this junior surgeon usually will come back to you and ask you what do you mean by this. Itulah.
All right. Thank you.
Itu based on my experience lah.
Yeah, thank you, Dr. Moha. Just to make sure that you are talking the same language with your surgeon. Maybe if you have a frequent CPC with your surgeons, whether junior or senior, so you can use your the correct term, which is if it is adenomatous nodule, you can put it in the what the interpretation. But somehow whether it is in the description or whether it is in the interpretation, but you must describe and mention the best word for that. I think if it is adenomatoid nodule, please mention adenomatoid nodule, whether it is in the description or interpretation, because it different. Many people interpret adenomatoid nodule as a follicular adenoma, for example, follicular encapsulated follicular carcinoma, encapsulated everything. So we should mention it there if there is apply if it is fulfill the criteria for the adenomatoid nodule. Just mention is it whether in description or interpretation. Yeah, I think that any additional point from our speaker.
No, I think it was explained well with my by Kawan and Moha. It's true. Unless it is the only nodule. Example, they operate for solitary thyroid nodule, and then it's actually hyperplastic nodule. Then you put that benign, okay, what you call that, adenomatous hyperplasia. If it is part of the 100 nodules, I think you don't have to put it in the diagnosis unless it is that dominant nodule that was radiologically suspicious, maybe TRAT4 whatsoever. Okay, so I think it makes it clear. Okay, all right. If any question, if you think of further question, you can message me anytime for those my friends.
All right, I think I have to end the session now because yeah, there will be a lot of discussion on this therapy. Maybe we can have another session only for that the dilemma part in the therapy. But your approach just now in therapy, your mnemonic and everything is just very fantastic, and thank you for that. And all right, so to everyone, and now the session, the weekend with IAPMD live is dismissed.